Right, okay, thank you for inviting me here to present this data on TB mortality among people living with HIV in Eastern Europe, which I am presenting on behalf of the TB HIV Study Group in EuroCoord. Let me just see this. So as I'm sure you're all aware, tuberculosis is a leading cause of morbidity and mortality among people living with HIV. The management of TB in this population is complicated by the fact that TB disease is often presented atypical and frequently involves extrapulmonary and disseminated disease. In addition, treatment regimens for TB can interact with ART regimens, which adds further complexity. The management of TB HIV co-infection in Eastern Europe is particularly difficult due to a very high prevalence of multi-drug resistant or MDR TB. A previous study from our group has shown that mortality rates in co-infected individuals between 2004 and 2006 were 3 to 5 times as high as in Western Europe. And last year we presented new data from the region showing that management of these patients is often suboptimal, with many individuals not having drug susceptibility testing performed baseline and initial TB treatment regimens with limited predicted activity against TB common. So building on this previous work, the aim of this analysis was to estimate mortality at 1 year after TB diagnosis in Eastern Europe as compared to Western and Southern Europe and Latin America. We were also interested in determining risk factors associated with death from TB, and we were particularly interested in studying the influence of the number of active drugs a patient received in the initial TB treatment regimen. We used data from the prospective TB HIV study, which is a cohort of individuals who were all known to be HIV positive, diagnosed with TB between 2011 and 2013, and aged above 16. So this study is a collaboration between 62 different clinics across the European continent and Latin America. For the purposes of this analysis, we've had to group the countries into different regions, so Eastern Europe, Western and Southern Europe, and Latin America. The key definitions for this analysis is baseline, which we defined as the date of starting the first anti-TB drug. The initial regimen an individual received was defined as all drugs received at baseline plus 10 days, and we included this time window to allow for staggered treatment starts, which are common in some countries in Eastern Europe, but we did do sensitivity analyses around it. We defined baseline drug susceptibility testing, or DST, as a test result from a mycobacterium sample taken within 4 weeks of starting TB treatment. The number of active drugs was calculated by linking the results from the baseline DST results to the initial regimen, and it is defined as the number of drugs in the initial TB treatment regimen to which no resistance was consequently reported. So just to highlight that this is a retrospectively calculated measure, and many clinicians did not know the results from the DST tests when they initiated the patients on treatment. So as it's not standard clinical practice to perform a DST for all possible TB drugs, we made the assumption that individuals were susceptible to drugs for which a resistance result was not reported, given that they had a result for at least one drug. But this assumption was also checked extensively in several sensitivity analyses, including one where we required individuals to have DST data on all the drugs used as part of their initial regimen in order for the number of active drugs to be calculated. We established causes of death using the CODE methodology, and we used standard survival methods to calculate the cumulative probability of and hazard ratios for TB death, with patients being censored at their last clinic visit, death from non-TB causes, or 12 months after baseline, whichever occurred first. So this is the baseline characteristics of the 1,406 individuals that we included in our analysis. As you can see, the majority of the cohort, 60%, received care in Eastern Europe, and the demographics of these individuals differed quite significantly from those receiving care in other regions. So just to highlight a few of these differences. Around half, or 52%, of individuals in Eastern Europe were also co-infected with hepatitis C. And over two-thirds, 68% of individuals in Eastern Europe reported ever injecting drugs, and this compares to around 20% in the other regions. Individuals in Eastern Europe were also more likely to present with disseminated TB and to initiate treatment that was not RH-based. In total, we had 576 individuals who had a baseline DST performed, and when we linked these results to the TB regimen individuals were started on to calculate the number of active drugs, we see that it was common to receive 2 or fewer active drugs in Eastern Europe, where around a third, or 31% of those with a baseline DST received 2 or fewer active drugs, compared to 2 to 10% in the other regions. MDR-TB was also more common in Eastern Europe, found in 39% of those tested for it. This compares to 3% in Western and Southern Europe and 17% in Latin America. And just to mention that there was considerable overlap between the number of active drugs given in the initial treatment regimen and MDR-TB, with a vast majority of individuals who received 2 or fewer active drugs also having MDR-TB. In total, we observed 265 deaths in the first 12 months after TB diagnosis, and 71% of these could be classified as TB-related. As you can see from the bar chart, the cause of death was most commonly TB in Eastern Europe, whereas the main cause of death tended to be non-TB-related in the other regions. So this Kaplan-Meier plot shows the cumulative probability of TB death according to geographical region. As you can see, the cumulative probability of TB death is higher in Eastern Europe, shown in the red line, where the probability of TB death at 12 months was 23%, compared to 1 to 4% in the other regions. And this plot shows the cumulative probability of TB death according to the number of active drugs in the initial regimen. Individuals receiving 2 or fewer active drugs, shown in the green line, were much more likely to die from TB compared to individuals receiving 3 or more active drugs, the cumulative probability of death being 34%. Individuals who did not have any baseline DST data were also more likely to die, at 17% by 12 months, and this compares to 6% for those who received 3 or more active drugs. And these findings were very similar in all the sensitivity analyses we did. Our findings were also confirmed in multivariable Cox regression models, adjusting for a range of variables which are listed at the side of the forest plot. So the risk of TB death was 3.5 times higher in those receiving 2 or fewer active drugs, and twice as high in those who did not have a baseline DST compared to those receiving 3 or more active drugs. Interestingly, even after adjustment, individuals receiving care in Western and Southern Europe, as well as Latin America, were considerably less likely to die from TB, the risk of TB death being 86% lower compared to individuals in Eastern Europe. Other identified risk factors for TB death were female gender, having disseminated TB and having low baseline CD4 counts. So we hypothesized that the effect of not having a DST performed at baseline may differ depending on geographical region and by proxy MDR prevalence. As you can see from these stratified Kaplan-Meier plots, the absolute risk of death was considerably higher in Eastern Europe for all the categories, also among patients who had a baseline DST and received 3 or more active drugs. However, when testing for an interaction formally in Cox regression models, that is, when testing whether or not the relative risks were different in the groups, we found no evidence to suggest that the relative risk of having an unknown DST differed according to region. And we think this could potentially be because of the small number of TB deaths in Western and Southern Europe and Latin America, which means that even very small differences between the categories will translate into reasonably large relative risks. Our study did have several limitations. So firstly, as I just mentioned, we may have had limited power to study interactions. And secondly, because of a lack of data, we weren't able to complete analyses on a country or clinic level. But I do want to highlight that clearly these geographical regions are very heterogeneous, and there will be differences both in the mortality rates and likely the risk factors for death that we could not describe here. In terms of generalizability, because some countries have been represented by relatively few clinics, this may limit how generalizable our results are. So bearing these limitations in mind, our study indicates that mortality from TB among individuals living with HIV in Eastern European countries remains strikingly high, with the cumulative probability of TB death being almost a quarter by 12 months. Some of the factors associated with an increased risk of TB death identified here are modifiable and include receiving fewer active drugs as a result of MDR-TB, starting an initial regimen composed without DST, and low CD4 counts. We believe that this data calls for urgent action to improve the care of TB-HIV co-infected individuals in Eastern European countries, and that such action should involve addressing the risk factors that relate to the clinical management of co-infection identified here. However, any efforts to tackle the excess mortality observed here will need to also address socioeconomic factors and challenges within the health systems of each country that limit their ability to provide high quality and comprehensive care to this complex and vulnerable population. So thank you very much for your attention. I'd like to finish by thanking and acknowledging the TB HIV Study Group, in particular Anna-Maria Werlinrud Efsen and Daria Podlakareva, who have coordinated the study and also interpreted the clinical data. And I'm happy to take questions.